Good morning, everyone. Thank you for coming so early on a Monday morning. My name is Jaden Tai. I am a second-year doctoral student in the Counseling Psychology program at U of L, and I go by he, him, his pronouns.
Okay. My name is Kenton Rossman. I am a third-year doctoral student in the Counseling Psych program. My pronouns are they, them, their. And what else can I tell them?
And we are part of the T-STAR Lab, T-STAR Lab, which stands for Transsexuality, Teaching, Advocacy, and Research. So pretty much as the name says, we do a lot of teaching, research, and advocacy related to trans identity and specifically within sexuality within the trans community.
Mm-hmm. And LGBT stuff broadly. So.
Right. And the reason why we're talking about these issues today is because as therapists and as counselors, you're going to encounter at least one trans client within your practice at one point or another. And this is important information to have to really provide competent, affirming care for trans folks. So we hope that today you can walk away with some basic knowledge and terminology related to gender identity, gain some knowledge of some of the common microaggressions or issues trans folks face in the therapeutic settings, gain knowledge of the therapeutic approaches to support trans clients in these environments, and really in general, how to be a trans ally, not only within the therapeutic setting, but also out in general, in public. How do we interact with trans folks in a competent and affirming way that really supports who they are and their identity. And with this training today, it's really just the first step to being trans competent. And we hope that when you walk out today, that you would go off and do your own research and educate yourself and further your education on how to be trans competent.
And we're happy to provide you all resources that will help with that process. But really, this is just kind of a jumping off point to have a broader discussion about trans issues as they apply to mental health settings.
Right. So let's start off. What is gender? And specifically, what does it mean to be a man or a woman? Anyone?
Not everyone at once. Take your time. Can anyone provide an example? I will call on people because I know you're not. Some people don't know that. What's an example of something that we might put in the category of man or woman?
Oh gosh. Some people could define it by hormones.
Okay, so hormone differences.
Kind of biological.
What else? Other folks?
What you identify
Okay.
as.
Okay. Who else wants to- Yeah.
What's socially acceptable as far as like clothing and how you present yourself?
So kind of how you express your gender and how that fits into that box. Which way is other folks?
Like a social construct,
Okay. Can you tell me more about that?
but they're not universal definition of it. And we kind of got stuck in a binary with
I'm going to raise this up because I don't have room to write. All right, so that's a little bit of difference of what, you said, that there is a Western construct to gender and between what a man and a woman is. So when we think about that and we think about sexuality and sex, what is the difference between sex and gender? This one's a little bit harder. So if I was to write, let's see, gender over here and sex over here, what would be the differences? Yes.
Sex is something that's biological and gender is something that
Okay, so biological identity. Okay. I know it's early in the morning. Stephanie again.
All right. Gender would include things like your gender expression, so clothing.
Okay. What about, so when we think about biology, what usually falls under biology? We think about hormones,
Yeah.
sort of like what we mentioned over there, right? We, yes.
I think like sex is more external and gender is more internal.
Okay.
Okay. Can you explain a little bit more?
Sex is like the physical characteristics and gender is just internal thoughts, feelings, identity.
All right. So with external parts, and it's more like a physiological, right? Is that what you're thinking? So when it, sort of like hormones, something more physical, like, or chromosomes,
Primary, secondary sex characteristics.
right? And then what about sex organs,
Yes.
right? Anything else? Kenton, do you have anything to add? No? All right, let's make it a little bit harder. What about the difference between sex, gender, and gender expression or sexual orientation? Fun stuff this morning. All right, so we'll get to that in a little bit with our one of our slides in the front. But just to let you know that everyone has a sex, a gender, and a sexual identity. You know, it's not just trans folks who have a gender or a sex or a sexual identity. But what else do we know about gender? What if I told you that gender is a social construct, right? And I'm going to pass it to Kenton because Kenton's really good at explaining this.
Can you all hear me? Okay, so as we have already mentioned, because you guys are awesome, gender is a social construct, so we haven't talked a little bit about what that kind of means in more detail. It means that the categories of men and women are binary categories, so there's one or the other, and we've kind of arbitrarily divided folks into these categories. This is influenced by social, cultural, psychological factors of how we define gender. And I think really important thing is that it's a complex process of socialization that changes through time and is culturally specific. So if we think about, here, I need you to move this way. If we think about what it looked like 150 years ago to be a woman versus what it looks like to be a woman now, we can see that gender changes over time. What counts as being a woman has changed. If we think about across the lifespan, what it looks like to be a man at 17 looks different than at 67, so it changes across even an individual's lifetime. All of these things kind of indicate that gender has a certain context and we can socially construct that context, culturally as well. Jump on that.
Right, so I just want to jump on the cultural aspect. So if we look throughout history and around the world, cross-culturally, that there are cultures around the world that have genders that do not fall on just a man or a woman, not this binary category, right? There's other cultures around the world, 150 years ago, or even now, where a third option, a third gender, is possible. So who are we to say that our way is right, our way of conceptualizing gender is a correct way and other cultures are wrong? Who are we to say that? So when we think about gender, we think throughout history and right now and across culture, we see that gender is a social construct. It's more than just, what our biological, physiological, external presentation looks like. It's way more than that. It's way more complicated. So when we talk about gender, I like to talk about it using genderbread person. Has anyone seen a genderbread person before? All right, a couple of folks.
I will say that this is the first version, so this is not the most complex version. It gets a lot more interesting if you go to the next version, but we usually do this for presentations at the beginning. But yeah, if you all want access to the more complex genderbread people, we can certainly get that to you.
There's a third version. There's a third version. This is the first version, and this is the most easy to introduce to folks who have never heard of the genderbread person before. So as you can see, it breaks things down between gender identity, gender expression, biological sex, and sexual orientation, and things are on a spectrum. Was there something you want to add?
I was just going to show when you pointed out, you pointed out.
Oh yeah. So with gender identity, we were talking a little bit about this, how we can have a man or a woman, but there's other cultures or other identities that fall outside of those two categories, right? That binary identities. So we have folks who fall in between or outside of the binary. We have folks who identify as genderqueer who can identify as, both a man or a woman or neither. We have folks who identify as gender fluid who are fluid and will go between man and a woman based on how they feel. That's just how they feel, and it really shifts. Was there something you want to mention?
I was just going to add that, for gender fluid folks, you can also switch between like a more, neutral androgynous presentation and man. Like you don't have to go across, just span the binary between man and woman. It can be a little bit more complex than that. That's
Right. It's 50 shades of gender.
It is. Yeah. But less coercive and more.
It's more consensual.
More consensual.
No. So, like you said, we said, gender identity is up in here. It's how a person conceptualizes and thinks about their gender, right? It's not necessarily their, which is what we were talking about, their physiological sex, their biological sex, which can even has it's on its own spectrum. There's folks who are female and male who have physical sex organs or genitalia that match the sex, but there's folks who are intersex, and there's folks who fall in between these identities, these sexes. So even with biological sex, there's a spectrum.
I would also argue that it probably happens more than you think it does.
Oh yeah.
For folks who are in this kind of middle gray, even though we make such clear distinctions between biological sex, I think there's a lot more gray.
Biology is very diverse. It's more diverse than we give it credit for.
I think so, and I think in our experience, a lot of times you'll see trans folks go to transition and then go to transition and realize that there was an underlying intersex condition they didn't know about, even though it didn't physically manifest. So I think there's a lot more gray.
Right.
Not
There's
just trans folks, but other folks as well.
And there's also chromosome differences that you can't tell unless you do a DNA check. So who are to say that they're more female or male than other folks that present the same way? And then when we talk about sexual orientation and the difference between sexual orientation and gender identity, you can see based on this beautiful genderbread person, that identity is up in here, and sexual orientation is who you're attracted to, it's who you love, heart. Aw, it's really cute, right? It's who you love. So that's on itself, it's on a spectrum. So you can go from straight to gay to bisexual, or folks who fall outside of that spectrum, pansexual, asexual.
I imagine many of you know this is a pretty simplistic version
It's very,
of the sexual orientation.
it's much more complex than that. And then we've got gender expression, folks who can be more feminine, can't talk this morning, feminine and masculine, or folks who are more androgynous, right? But these are all separate constructs. These are not necessarily related to each other. So you can have a person who was female assigned at birth, who identify as a man, who presents more androgynously, a good mixture between, feminine and masculine presentation and performance, but are attracted to men. So they would be a gay trans man or a gay man. Way complicated, but simple at the same time. Is there any question about this? So just to give an example, I'm going to use myself as an example. I identify as trans. I am a trans man. So that means that I was female assigned at birth, and I identify as a man. And as you can see with my presentation, I'm more on the masculine side of the gender expression. But I am attracted to women, so I would lean more towards this side of the sexual orientation spectrum. I just disclosed a lot about me on a Monday morning. It's fine, I'm still here. So when we talk about trans folks, we are, especially right now in this presentation, we talk about this general trans umbrella, right? And when you start a spectrum, there's 50 shades of gender. Anyone can fall anywhere on that gender, and they would be completely different from the person next to them on that point, right? And there's a lot of identities that fall under this trans umbrella. All of these. So trans generally encompasses any individual who crosses over or challenges their society's traditional gender roles and or expression. And we do, I'm going to go straight to this one. We do research, qualitative research with trans folks in Kentucky and in the Midwest area. And when we collect identities, how people identify, they all identify as trans, but when you ask them specifically how they identify, these are some of the identities that they identify with. Right? There's a lot of them, and this is just the tip of the iceberg. And so when we go back, when we talk about trans folks, we don't talk about transgendered or transgenders. You know, transgender is an adjective, it's not a verb, it's not a noun. We are more than the sum of our parts, right? We are more than just one identity. When I talk about myself, I talk myself as a trans person. I'm not a trans. And I don't transgender anything. This is just who I am. And you won't find us using the words transsexual very often. There are certainly a lot of trans folks who do identify as transsexual, but we don't use it, especially in our presentation, because it really denotes a more medicalized term. It was a term that was invented by the medical community. It's also a very binary term, right? It usually denotes a man or a woman, or a trans man or a trans woman. There's not a lot of in between and a lot of space for folks who identify off or within that binary. So we're going to use trans. But as you saw with this, there's a bunch of other identities that fall under it. So that includes trans masculine, trans feminine, gender variant, gender nonconforming, and gender fluid. And you know, some identities, some gender identities are more consistent, and some are more fluid. And that's okay, because gender is a social construct, and it's all about what's in here, right?
I just want to say, I think that can be an area that can be challenging for clinicians, especially if you're working with a trans person. You feel like, okay, they've identified, but now they're moving around a little bit, and I don't know what that means, and maybe I did something wrong. And by moving around, I mean like they're kind of oscillating maybe in their gender expression or presentation or how they think about their identity. That's pretty typical, and I just would throw it out there to not panic if you're working with a trans person and all of a sudden they're like, well, maybe I'm really more androgynous than this. I think a trajectory we see a lot of times for folks, especially if they're binary identified, is you know, I'm going to transition from female to male, so I need to be the coolest dude, I need to be the most hyper-masculine dude, and then as people kind of go through that process, they usually kind of back down a little bit from that, but they're kind of learning a whole new gender. So you know, you give clients a little bit of space to work through those problems and not think that something's wrong or that they did something wrong just because they're moving around.
Or that they're not trans enough.
Right, well.
Right? When we think of trans, we usually think that this is some static identity, and it's not the case. I have a gender fluid client who oscillates back and forth. You know, one session, 1 week, they are more neutral. They identify with both or neither. And some weeks they're more men. They feel like they're more of a man today. And then sometimes they'll switch in the middle of session and they feel more of a woman. And that's okay. It doesn't mean that they're any less trans than, you know, the next trans client that I have. That's just who they are, and that's how they identify, and that's what's going on in here.
Yeah, so I would think about the identity trajectory and then also about the stability of that gender, right? So we have a fluidity versus the consistency, and then also kind of where they are in terms of their identity, like trans sensitivities.
So just a couple more terms and definitions. Go back one? Okay.
With this, the other thing I just wanted to point out is, like, this is a ton of labels. I don't expect you all to understand what every one of these labels is. It's a lot. The point is that no two people, if they identify this way, will present or think about their identity the same. So the key here really clinically is to open the space up for people to talk about it, understand there could be a variety of labels, understand that that's okay, and really ask your client what that means to them. Because I can work with a trans guy and think I know what a trans guy is and really be, you know, counter-therapeutic because I'm projecting my idea of a trans guy onto this guy. It may not be his idea of being a trans guy. So that would be what I would advocate in terms of clinically working with folks, is just knowing that there are a lot of labels. You're probably not going to know all of them. We could try to define them now, but they're not going to be correct, because somewhere else it's going to mean something different, or for someone else it's going to mean something different. So just ask your clients and try to be open to what they're saying and understand where they're coming from in terms of their identity.
Right, so I identify as a trans guy. If I go up to the next trans guy somewhere down the street, if I ever meet one, the way that they conceptualize their identity, who they see, how they see themselves, is going to be different from how I see myself and how I conceptualize my identity, even though we go by the same trans identity label.
Also intersectionality. I mean,
the intersectionality, you know, we have a bunch of other different identities that also influences our gender and how we see our gender. We can talk more about that if we want. Nate? Yes. I ask them. Especially when I write my notes, I ask, what pronouns do you want to use for me to use today? How do you identify today? And they will tell me, and they actually really appreciate that I actually took the initiative to ask them, because with trans folks, there's so much distress for the mental health community that they don't feel like they have a voice in our session. So when we give them that voice, we're putting the control in their hands, and we're letting them be self-determined about who they are, and that gives them a lot of power.
How did you know in the middle of the session? Like mid-session?
Because we were talking about it. We were talking about how they were oscillating back and forth. So it was very specific to that client. Yes, Dr. Boucher.
Can you describe the flag that's up on the screen,
Oh, this is a trans flag.
what it symbolizes?
Well, so with the blue, you know, historically, that's generally considered like boys, right, men. Pink with girls or women. And then we got this white spot for folks who identified in between that, you know, anyone. So it encompasses all the genders.
There's also like a non-binary flag and a million kinds.
There's a bunch of different flags in the community. I'm not going to go through them because that would take forever. So let's talk about, you know, a little bit, a couple more, just really quickly. When we talk about people's body, trans people bodies, or just bodies in general, we use the term sex assigned at birth. So for example, I would be female assigned at birth. I was given this sex at birth based on what my physical external presentation is looking like, right? Same with male assigned at birth. More questions, there's a Q&A towards the end, but I feel like we're down on time, a little bit behind. It's fine. And then dysphoria, folks have heard about the term dysphoria. It's in the DSM, gender dysphoria. So it's more of this incongruence between how a person thinks about, conceptualizes their gender, or feels their gender, and how their body is being able to present it, right? And then,
It's that distress component. The distress felt when how you think about yourself in your head doesn't align with your body.
right, the anxiety,
Or societally.
and stress. So, and some folks, when they experience dysphoria, they have this need to alleviate that stress and this anxiety. So folks opt to transition, and you can socially transition or medically transition. Socially transition is more of coming out to yourself, coming out to the people around you, your loved ones, and then start presenting your gender and expressing your gender in the way that you that you feel like your gender is. And with medical transition, you usually have to, does hormone replacement therapy or gender confirmation surgery, you know, top or bottom surgery. And that's a more medicalized part of the transition, and not all trans folks opt to medically transition. So to keep that in mind. And we'll throw around the term cisgender or cis, and it's for folks who don't identify as trans. It's folks they identify with the gender that they were assigned at birth. So if you currently identify with the gender that you were assigned at birth, hooray, you're cisgender, you have your own gender identity. You know, we're not special, we don't get our own identity, everyone has a gender identity. And we'll talk about cisnormative. Has anyone heard of the term heteronormative? Right? It's the same concept with cisnormativity. It's this assumption that everyone around you is cis or identifies with the gender that they were assigned at sex, and that's not always the case. And that's this assumption that perpetuates this idea that trans people don't exist.
Or puts trans people in a lot of danger.
Right. And so let's talk about the very real experiences of trans folks. 80% of trans students have felt unsafe at school because of their gender identity or gender expression. Folks have been verbally harassed, and some even physically abused. And it doesn't only come from their peers, it comes from their teachers, their faculty, their administrators within the building. So it's not just amongst each other. 50% of trans people have been raped or assaulted by romantic partners. 30% of trans women have been incarcerated. And when it comes to trans women, they have a 1 in 12 chance of being murdered, and the rates are even higher if they are a trans woman of color.
Wait, can we go back to that for a second and really think about the fact that 1 in 12 trans women has a chance of being murdered, and 1 in 8 trans women, if they're a woman of color, has a chance of being murdered. I don't know of any group that has that level of risk in terms of physical violence against them. So I want to take a second and think on that. You can go on, but I think it's a really powerful stat.
Yeah.
And talks about the needs for this community and the clients that we see.
And just imagine the stress,
Yeah.
the everyday stress that folks have to go through, especially trans women of color. There's going to be a lot of physiological and psychological health problems that come with that. Just to quickly, a little bit more, 41% of trans folks can't change their gender on their identities, whether because they can't afford the surgeries that are required to change their identities, or they live in a state that have laws, explicit laws that prohibits any kind of change on their gender, on their identities, regardless of the surgery that they have. So when you practice anywhere in the country and you work with trans folks, think about that and take consideration how the laws affect your clients. 57% of trans folks have been rejected by their families, and 19% of trans folks have experienced homelessness. And within this 19%, the vast majority of them are trans youths. So if you work with trans youths, take consideration of that as well. 19% of folks have been refused medical care, an incredibly high rate of folks, trans folks, attempt suicide, right? Incredibly high. So with all this stress from not only internally but also externally, there's a higher rates, they encounter higher rates of health disparities, such as higher rates of smoking, higher rates of HIV infection, 4 times the general population, higher rates of drug and alcohol use, and as you saw, 47% or just really high percent of suicide attempts versus the 1.6% of the general population. Incredibly high for this population.
So is there a way to understand these experiences a little bit more ubiquitously? So Myers-Briggs stress model was first published in 2003, and initially was applied to LGB populations, and then some research has come out that kind of applies that more to trans folks. The idea of this is looking at why are there such desperate and different mental health outcomes for LGBT folks in general. The idea here is that experiences of discrimination increase experiences of stress and lead to poor health outcomes. So this works by individual experiencing discriminatory events, right? So you either have an acute or chronic stressor that you need, like, you got kicked out of your parents' house, and that's a stressor. Even if you didn't personally get kicked out, you know that your friend got kicked out because they're trans, that increases your stress. So you have that experience. And then you keep waiting for that thing to happen again. Is this person gonna wait on me? Is this person in the clothing store gonna help me? Is there gonna be an issue when I go to the doctor?
Am I gonna get killed?
Am I gonna get killed? Am I safe to walk outside at night? All of those things compound, so we have experiences of stress, increased hypervigilance around stress, and then internalized feelings around your identity and who you are. So we'd call this internalized transphobia, similar to internalized homophobia. So feeling bad about yourself, feeling negative about yourself, feeling bad about your community sometimes, these are all experiences of internalized transphobia. These factors combine to increase the stress and the mental health outcomes for trans and LGBT folks broadly. Does that make sense?
So as you can see, trans folks encounter a lot of stress, a lot of anxiety. So really, trans folks need a lot of care. They need care from us as therapists. But there's a twist, there's barriers to care even within our healthcare fields, right? As we saw earlier, 1 in 5 trans folks have been refused medical care due to their trans or gender nonconforming identities, and even higher among trans people of color, right? So this happens not only in doctor's offices, in hospitals, emergency rooms, mental health clinics, with EMTs and drug treatment programs. It happens everywhere. And I recently conducted a study about the healthcare experiences of trans folks in Kentucky, and what I found is that nearly half of my participants felt that their healthcare providers was not trans competent. Right? That's concerning. 4 out of 5 folks had to educate their providers of their very basic needs. Who would be frustrated and angry every single time that you walked into a doctor's office or walked into a therapist's office or trying to get any kind of healthcare access that you have to explain your identity, who you are, what your needs are every single time, when sometimes it's what you need are just emergency care. So there's a lot of distress with the medical care community and the mental health community.
And there's a lot of subpar care.
What?
There's a lot of subpar care.
Subpar care.
People aren't getting the level of care that they deserve.
Right.
Another mentally and in terms of medical and mental health.
And well, right, so there's folks who encounter microaggressions and issues in therapy, right? There are therapists who don't understand trans identity or assume the gender identity of their client based on their gender expression or their physical presentation. There are therapists who either unintentionally or intentionally misgenders their client.
I want to point out I had a trans friend who was in therapy for 6 months and got misgendered by her therapist on the phone, which I think is pretty impressive. based on that there's no reason to use third-person pronouns on the phone, but yet was misgendered by her therapist after 6 months and having paid this person quite a bit of money. It happens. It's very frustrating, and it's unacceptable.
These things happen more often than you think, right? There's, just to continue down the list real quick, there's therapists who have refused to acknowledge a trans identity or sometimes slip after 6 months. That's unacceptable. There's a refusal to understand non-binary identities, saying that non-binary identities, identities that are not male or female, do not exist. And then there's folks who refuse care. You know, I know trans folks who have been turned away from medical and mental health services because they are trans, and that's unacceptable.
Well, we're not talking about like, oh, here's a referral for someone who specializes in this. We're talking, we can't serve you here, you need to go somewhere else.
Right.
Right, so not a proper referral service to be like, oh, I need to get you with someone who's more competent than I am, I don't know anything about this, but just denying care outright.
Thank you. Folks, some therapists think that every problem that their trans client is going through right now is all because they're a trans identity. It's not. Sometimes it is, but not always, and that's something that you have to think about. Or assume that sexual orientation is based on their trans identity. As we saw with a genderbread person, they are different. Not being up to date with trans care, you would be surprised at how many folks who claim that they are trans competent are not up to date with their trans care.
Or who claim that they're LGBT competent and don't know trans people.
That too. The T is there, whether you like it or not. Some folks deny letters that are sometimes required for hormones or surgery or any kind of medical transition. Some do not provide the adequate resources or referrals, and some, do not provide affirming competent referrals for their trans client. And when it comes to APA, we have policies about working and with trans folks and providing non-discrimination care. And you can, it's a huge list. It's a huge thing. You can go to this website if you want to read all about it. But APA is pretty explicit about our stance on this. And when it comes to our ethics, we have ethics to protect our trans clients, right? We have to do no harm, and we have to do good for our trans clients. We have to provide them with, we have to treat them the same way that we would treat them with any of our other clients, with the same dignity and respect for who they are and their self-determination. And really, overall, we just have to avoid doing harm. You know, if you can see a trans client and just not make things worse for them, that's already something, that's that, you know, that's something different that they're encountering from the real world. So these are quick snippets of some of the participants from my study. One person said that there are a lot of really poor psychiatrists in Kentucky who seem 30 to 40 plus years behind and have no interest of staying current. So it's what we were talking about, that these people who were saying that they're trans competent or LGBT competent, they are so behind in the literature, in the research, or just where the community is at right now, that they really should not be seeing trans clients. They are actually doing a lot more harm. Kentucky is the absolute worst place to come out and attempt to transition. I was harassed by multiple mental health providers because of my identity. This is in Kentucky, folks. Also, there are plenty of mental health providers who say they serve the LGBT community, but I was usually their first, and they really knew nothing. I count 4 counselors, maybe 5 in the Louisville area, who really understand the transgender dilemma, and the numbers are even much lower outside of Louisville and outside of Lexington.
I would claim that if this person, I refer to 2 people in the city of Louisville. I don't know anyone in Lexington specifically, maybe another 2 people that I would refer to in Lexington. That's it for providers in the state. I have a friend who works in private practice who is seeing clients who are driving 3 and 4 hours to get mental health care. Not medical health care, not endocrinologists, but just like, I need a therapist. Part of that's because they don't feel safe in their communities for those clients, but also the other part is that there's no one in their community to provide those services. So this is a real crisis in terms of access to care and people getting the basic mental health needs that they need. They can go and get treated for depression, but when gender identity stuff comes up, they're not getting their care needs met. I don't right now have anyone I could refer to at 7 counties. So especially when we talk about low-income folks and trans folks, there's a lack of services there as well. So there are some really systemic barriers that are impacting this community and getting them the care.
I know when I was trying to find my own therapist, for a variety of reasons, part of it is with my gender identity, many years ago, I had to fight tooth and nail to find one that I felt comfortable with, that I really understand who I am as a person, not just my trans identity, but me as a whole person. It took me a while, and it took me, multiple therapists to get to that point, and I've been through therapists who really did not know what they were doing. I was their very first trans client, and I was pretty much their guinea pig. That's not a fun feeling. I didn't want to educate my therapist on everything about trans or where I am, because I'm educating myself. One last one. She told me at the end of my appointment that she doesn't think that I'm trans. It's very rare in women, and I should experiment in dressing like a butch lesbian, lose weight, and sleep around. She said I had other problems and I would be run from them by transitioning, and I was devastated. This person wrote a huge response to this open-ended question, and they went on to talk about how after this happened they had a mental breakdown, spent a few weeks some time in a psychiatric hospital, and really was fearful to address their gender identity for years. And they were talking about how they wish that they had competent affirming care to really address their gender identity early on, because they could have been happier years earlier, but instead spent years in distress. So when we think about trans people's experiences and seeking mental health services.
Well, another thing, in a similar vein to this, I've had a friend who's working with some trans folks who are younger, like 18, 19, and they went into mental health systems, psychiatric systems, as teenagers around identity stuff, and no one addressed it. So they also lost years, because here's the thing that's happening, no one knows what to do with it or how to talk about it, we're not going to really touch it. And so then they've lost. I mean, so these people are losing years of being, hopefully decreasing their mental health symptoms, having better outcomes, feeling more confident about who they are, because at these points of care, therapists aren't, this person doesn't have to be able to treat this person has to be able to say, hey, I see what you're going through, let me get you someone who can, right? I mean, it doesn't have to be you take this person on by yourself, but if you say these kinds of things, you're going to negatively impact trans folks who are already really struggling in terms of mental health and medical health access to care.
Right, and as therapists, we have to be comfortable with being that point person for trans folks. Sometimes you are the very first person that they come out to, or the very first person that they even openly admit that they're having issues with their gender. And you have to be okay with that, and you have to be able to affirm and support them in that moment while trying to seek out appropriate resource and referrals for them. Or supervision, right? You have to be comfortable, because that will happen. Maybe not now, maybe later on.
But someday.
Someday. But we know the effects of folks who don't get competent care. We know the effects of folks who face anxiety, distress, discrimination, outside in the world. And if they can't find resource or a safe haven in the therapeutic environment, then what good are we? When it comes to trans suicide, we were thinking, there's so many young trans people who have committed suicide just this year, right? This is still March. We're at the end of March. It's been 3 months. These are 5 very public trans teen suicides, many of which because they've been rejected by their family, many of which were not able to get the competent care and the supportive care that they needed from the mental health community. We weren't there to be able to support them and affirm them for who they are in their times of need when they didn't have anyone else. So we really have to be their advocates. We really have to be those people who are finally there to support these folks, because if we're not, this stuff happens more often than you think.
We've talked a lot about transition. I'm going to go into that in a little more detail. Jaden hit on some of these things, but I want to be really specific, because I think it's important for mental health providers to kind of know what we're getting into when we're working with trans folks. First and foremost, transition is made to alleviate gender dysphoria, which is this incongruence, as we've talked about. So the idea is you're moving people towards congruence and feeling better about their identity. Their identity is more representative of who they really are. So there are 2 different ways that we usually approach this. There's a social and medical transition. So social transition looks like things like changing names and pronouns, changing your gender expression like haircut or clothing, making an announcement, There's recently a story about how some parents, when their kid came out as trans, put another birth announcement in the paper saying that this is our kid and this is how he identifies, blah, blah, blah. So those are some ideas of what can happen with a social transition. And then we have the medical transition. So for youth, for people who are pre-puberty or in the early stages of puberty, hormone blockers are something that can be used for youth. And then there's also hormone replacement therapy like we've talked about in surgeries. So all those are what we kind of generally put into the medical transition. Some folks may do things like electrolysis or certain facial surgeries or body contouring surgeries. Those things can also be part of a medical transition for folks. They're less commonly talked about. This is usually the kind of like holy grail of all the medical transition things or hormones and surgeries, but those are other things that people can do. So I've talked a lot about trans folks accessing care and what that looks like, but maybe it's important to kind of contextualize how many trans folks are accessing care. We know that trans folks depend on medical and mental health services to get their needs met in terms of their transitions. 75% of trans folks report having sought therapeutic services, with another 14 hoping to do so in the future. So that is, I don't know any other population that seeks mental health services at that same rate. So yes, there aren't that many trans people overarchingly, but they are seeking mental health services at a rate that's atypical for any other population. In the same vein, 62% of trans folks report having had hormone therapy, and another 32% or 23% hope to do so in the future. So both of those are factors that are, once again, a small group of trans folks, but they're really accessing these services at a high rate, and that's important to keep in mind. So what about, you have a trans client come into your office, you're going to start working with them. We're going to talk about this a little bit, about the diagnosis that we give to trans folks, especially if they're seeking out medical services. And that diagnosis is gender dysphoria. It's the new terminology being used in DSM-5. In 4, if folks remember, the diagnosis was gender identity disorder. That diagnosis has been taken out because the thinking was that it pathologized the identity. And the goal with gender dysphoria is to emphasize the stress and the incongruence related, not the identity, right? So the dysphoria is what we're targeting, this distress part, not this identity that we're saying is pathological. There are 2 different criteria for children and adolescents. So think about that, especially if you work with youth. Adolescents can be pretty broadly defined as 12, 13. So there's a whole different set of criteria for kids that age as opposed to kids under that. Thinking about where they are in puberty, those are the kinds of things that impact the differences in those diagnoses. And then it also includes an alternative gender option. So in 4, it was written in a binary way. Someone who wishes to be the other sex, or the other, I think it was sex in 4, wishes to be the other sex was a kind of terminology used. In 5, what we're seeing is someone who desires to be the other gender, or, quote, like in parentheses, or an alternative gender. So what this does is allow space for people who may identify in a non-binary way to access medical services. And then conversely, it also puts non-binary people in a new mental health label. So for me, I don't have very much desire to access medical services, but I'm now included under gender dysphoria where I wouldn't have been under 4. So that might come as a surprise to folks if they've had a different diagnosis or they didn't think that applied to them and now it does. Some of those may be changes for folks that you may be seeing, but just to think about that. So yay, it gives people more space. So like I worked with an agender client who was 18 and who used female pronouns, and she wanted access to top surgery to remove breasts. And we could do that because she fell under this gender, the gender dysphoria diagnosis, and B, we found a provider who would do that. So this is something to keep in mind. So we have this gender dysphoria. We have an idea of what that looks like. But we should also really talk about these kind of co-occurring mental health conditions. So what we see a lot with trans folks is depression and anxiety. I believe 61% of trans folks have reported experiences of depression. So we're seeing a high level of comorbidness between depression, anxiety, and gender identity that generally go down as the transition process begins. So the whole point of having a gender dysphoria diagnosis and access to medical care is to alleviate the mental health symptoms that come with not having that access to care, right? So we're providing hormones, people will hopefully decrease their anxiety. We're providing hormones, hopefully people will decrease their depression by doing surgeries. All these things will hopefully decrease for trans folks. And with children, we see some externalizing disorders, oppositional defiance disorder. One thing I want to point out here is that for kids, we also see this depression and anxiety at high levels, but kids who internalize actually do better than kids who externalize. So trans kids who are acting out are getting into more trouble, having more issues, and have worse outcomes than kids who are internalizing it. Neither is ideal, but in some ways I can see for youth being protective and keeping it to yourself is more advantageous than going out there and because you face a lot of bullying and aggression, or rejection from school or rejection from family. We see a higher prevalence of autism spectrum disorders with trans folks. And additionally, what I would look for in working with trans folks, substance abuse, history of trauma and abuse, and suicidality. Those would be things that I put on my list to check for. So treatment for gender dysphoria, and this kind of goes a little bit more of a youth focus, but what can you do if you have a trans client at any age, but especially if you have a youth? Well, first you can talk about changes in gender role and expression. You can do that anytime at any age. So if you have a 5-year-old who highly identifies as a girl, letting that kid dress as a girl is a good first step to hopefully alleviating some of this gender dysphoria. Working with parents and schools and families is key and critical when working with trans youth. There's so many barriers around that to keep in mind, but you have to work really collaboratively with everyone, and including medical providers. For kids who are, like I said before, like pre-puberty or early puberty, so like Tanner stages like 1 and 2, I think, they can be put on puberty suppressing medications. This is atypical. I don't know if this can be done in this, I don't know anyone who provides this in this community. It may be happening, I don't know. But this medication is extremely expensive, probably $1,000 a month. Insurance doesn't cover it. Insurance doesn't cover hardly anything related to trans folks in a lot of cases, so that's something to keep in mind too. But that's something that can happen. So what you do is you suppress puberty. You let that kid generally go to 16 because that seems to be the cutoff that doctors feel comfortable with. And then you allow them just to go through one puberty, and that puberty aligns with the gender that they feel like they are inside. Right? So one of the areas that we see issues with for trans youth is that as a small kid, I think something that you could see that's pretty common is trans kids thinking like, well, I know I have a penis now, but when I grow up, I'll have breasts because I'm a girl, so I should get breasts, and girls get breasts, and that makes sense. And then when kids go through puberty, you experience these higher levels of dysphoria and upsetness and difficulty dealing with things because their bodies are changing in ways that don't align with what they think in their head. And that would be terrifying. If you went through a puberty different than you thought you would at 11, I think you all would be pretty upset too. So keeping that in mind when you're working with youth is that puberty can be a really upsetting process for some kids. Like I was saying, hormone therapy for trans folks, usually the early stage you can get is 16. That depends on the provider. That's to feminize or masculinize the body. Testosterone is used for, I'll just say kind of broadly, trans-masculine folks to masculinize the body. And for trans-feminine folks, usually you do some variation of estrogen and a testosterone blocker. So you block the testosterone, increase estrogen, and you get feminizing effects on the body. Generally, the younger these interventions are done, the more the bodies change. But the body changes due to the hormones. So people start young, like 16, they can even get some bone structure changes. It's really interesting that there can be some really impactful changes to folks if they start young. Then we have these surgeries due to changing primary or secondary sex characteristics. So like I was talking before, like removing breasts is something very common for trans guys to want to do, get rid of their breasts, have like a double mastectomy. Also changing genitalia, so there's some surgeries for trans guys and some surgeries for trans women. Those are hardly ever covered by insurance and are highly expensive. So I would ballpark bottom surgery for trans women being around $30,000, and bottom surgery for trans guys.
It can vary between $60,000 to $100,000.
Yeah. So
many places in the U.S. You can hardly find anyone in the U.S. that will do bottom surgery for trans women or trans men. Most of the trans folks in the community, in order to get bottom surgery, will have to go to other countries. Sometimes, I think Thailand is the
It's pretty
place
common.
that a lot of folks go to.
Mm-hmm.
One, it's a little bit, it's still not cheap, but it's still really expensive, but at least the technology there and the research there is much better than what we have over here.
Yeah. My point, letting you all know this, is just to get an idea of the kind of barriers that trans folks are facing. So if they feel really depressed and hopeless that they'll never get bottom surgery, it's because they never get bottom surgery. Like $100,000 is a lot of money. Yeah. I don't know specifically off the top of my head. I know that there's a very high, very low rate of regret. I can talk to you personally about experiences of folks having been really happy that they had that surgery and taken out that money. But I can't give you like a specific number off the top of my head or like a degree to which it decreases depression and anxiety. We know that generally the treatments for gender dysphoria alleviate depression, anxiety, and that kind of stuff. It's also important to keep in mind, especially in this community, that insurance is spotty. So one thing that I see folks doing, especially trans folks, is maybe taking lower wage jobs at places that are national to get access to trans health care. So like, I can go work at Walgreens and be a cashier, and even though I have a master's degree, but at Walgreens, I can get trans health care. And then I will I work at Walgreens for 5 years and transition and go do something else. So we also, like we had talked before, we see lower wages and more folks living in poverty. Some of that is the transition stuff, but some of it also is just feeling like if I have to work a lower wage job to be able to transition, that's what I'll do. So, and anyway, the access to surgery occurs generally after 18. Are there any questions? I feel like I kind of sprinted through that.
Insurance do not cover, rarely ever cover any surgery, and sometimes do not cover hormones, or a lot of times doesn't cover hormones, and sometimes does not cover therapy, once they find out that it's because it's trans-related.
Yes, so people get really panicky. Trans folks historically have gotten really panicky around what you put on, like, what do you put on their records, all that kind of stuff. If an insurance provider, people are afraid that if an insurance provider finds out you're trans, they're going to more systemically deny you coverage. That shouldn't be happening, but it still does. So there are stories of someone who's a trans woman who's on a softball team, and she broke her arm playing softball, and they said, well, gay softball is trans-related, so we're not covering it because it's related to your trans identity, right? Those kinds of ways that insurance companies have found historically to kick trans folks out and not get them any access to care freaks people out and makes them really concerned. So I would think about that if you're working with clients in a college counseling center. You're maybe not providing diagnoses, but if you're in the community, talking to folks about what diagnoses they want and how that might look and where you want to keep those records. For trans folks in the military, they can still get kicked out for being trans, so making sure that you're very cognizant of that. If you put it in your medical records and the Army comes and takes them, you've outed your client. Do you have anything else?
I just want to quickly say, in my research with the trans folks in Kentucky, the majority of them have insurance coverage, right? 70% of them are terrified that once their insurance finds out, if the insurance finds out, that they will be dropped from their insurance coverage completely. They are terrified, and that adds to that minority stress model. That's an additional level of stress that they have to encounter on top of everything else that they have to deal with. So it's something to think about. So there's systemic barriers going on with trans folks.
And this shouldn't be happening under the Affordable Care Act, and we're just seeing the first wave of legislation around people like getting terrible care and being trans and like suing providers. But we're just doing that now. So this is in motion. This will hopefully get better in the next 5 years or so, but right now this is where trans folks are. For children, we're talking about treating gender dysphoria specifically in children. Gender dysphoria can be evidenced as early as 2. You can have very young children be very clear about who they are. I am a girl. I'm a girl. I don't know why you're calling me a boy. I'm a girl. Very clear. Indicating that they don't like their bodies. Those kinds of things can happen. Like I was just saying, they may express a wish to be another gender, unhappy with their physical characteristics and functions. They may prefer kind of what we think of as more stereotypically gendered kinds of things, so princesses and Barbies or trucks and cars. I don't find that to be a fantastic diagnostic criteria, even though that's included in DSM-5, but it is something to think about. So we know that they're trans youth, but just how many are they and how old are they? So we know that 1.3% of middle school students will identify as trans, self-identify as trans. Half the youth that present for transition-related treatment at a clinic generally are pre-puberty or in the early stages of puberty. Trans youth on average realize that they have an incongruence around age 10 and self-identify as trans by age 14. So these are pretty young kids. And these stats are a little bit older, so you're probably going to see, I would think, Aiden, younger and younger kids being cognizant of their gender earlier and expressing that earlier. So what about the barriers faced by trans youth in general? So this is a graph looking at the experiences of harassment and assault based on gender expression in schools. This is from GLSEN. What they've done is they broke other gender and transgender into 2 different groups. Transgender includes more binary identities, so male to female, female to male, that kind of stuff. And genderqueer folks, and then they put everyone else who identified in another gender category. It's a weird breakdown, but we can see the results here kind of the same. So we have verbal harassment, physical harassment, and physical assault. For kids who identify kind of outside the binary, we see that about 60% of those kids experience verbal harassment, 25% experience physical harassment, and 10% experience physical assault. When we talk to kids that they typify as transgender, we see 75%, a little bit more, experience verbal harassment, 41% experience physical harassment, and almost 16% experience physical assault. So schools are not a particularly safe place for these kids in general. And if we look at this other graph around impact of family acceptance and outcomes, it can give us a little bit more idea about what's happening. But we know that overall 57% of trans folks experience family rejection, but not having family rejection, having family acceptance can make a huge impact on outcomes for youth. So in terms of use of alcohol, tobacco, drugs to cope, 19% of kids who have acceptance use it compared to 32% of kids who don't. Smokers, 27% of kids who have acceptance smoke, 32% of folks who are not being accepted smoke. Attempted suicide we see at 32% versus 51%, the higher number being kids who are rejected by their families. Underground sex work, 11% of kids who are accepted by their families participate in that, while almost 20% of kids who are rejected participate in that. Incarceration rates are about the same, so 11% and 19% for kids who are accepted and rejected. And then the big one here, I think, is the take-home is the experience of homelessness. So for kids who are accepted by their families, only 9% experience homelessness, while kids who are rejected, 26% experience homelessness. So I would say in general, whatever setting you're working on, if you can work on family acceptance and family connectedness. We just did a presentation for U of L psychiatry. And that's one of the things we talked about was how do you get families to be accepting, especially if someone's in crisis, how do you not get that family disconnect, because we're going to have a lot worse outcomes if people completely lose their families. So as a therapist, you can practice what we would call trans-affirmative therapy. The purpose of trans-affirmative therapy is that the therapist is not an evaluator, but a collaborator. So kind of changing the frame from evaluating someone to see if they have gender dysphoria to working with them to deal with these issues. Clients and therapists, the client and therapist are engaged in supporting the client's identity development. Therapists should not, one of the things that we get concerned about with therapists is looking for causation. What caused you to be trans? Please don't do that. Please don't. Exploring future options with clients is good. What do you want your identity to look like? What do you want your life to look like? Those are fantastic. Help clients get greater self-knowledge. And really the key is here helping them make informed decisions about their identity, their transition process, and their direction in life. So kind of providing that space to kind of help with that identity stuff, which is a lot of what we do with, especially in college counseling center settings. This is something we do with a bunch of kids, right? What's your identity? How do we help you access? What does your future look like? Therapists should acknowledge and understand that not all trans clients express gender variance or even gender dysphoria, or even looking for the same solutions. So just because you know that for a lot of trans guys, hormones work, and this is the trajectory that should be done, doesn't mean it will for every client. So being open to that. And also that gender is simply not about surgery or hormones or even transition. So trying to think more broadly about how gender impacts someone's whole life as opposed to just trying to check off these things that should alleviate the dysphoria, trying to work with the whole person as opposed to parts of a person.
It kind of goes along with that when you see a trans client, is this historically what we think about our role as a therapist is, are they trans or not? Is usually, do they want surgery or not? Or do they want to go through medical transition or not? Oh, you don't think you're not trans enough. That's usually a narrative that is commonly heard in the trans community, that they are assume that they're not trans enough just because they don't want any kind of medical transition or experience dysphoria very differently from this general narrative that we usually hear in the community, and that's not the case. And that's something that we really want to, one of the driving points that we want you all to take away today. If you take anything away today, take away that the trans community is incredibly diverse, and we're all different. We identify differently, we conceptualize ourselves differently, we want different things, we experience dysphoria and other things very differently from one another, even though we're all part of this greater community. So that's something that I just really want to drive home, that with me, I'm gonna want and experience things very differently to the next trans man or to the next trans person. With me and Kitten, we experience very different things, even though we identify under this ubiquitous trans umbrella.
Yep.
So that's something I just want to really drive home real quick. Sorry.
Sure, yeah. We have this one mic situation too we're trying to work on, which is why we're being a little weird.
I just want to go.
One thing I would throw out in this kind of same vein is thinking about body dysphoria and difficulties with a body versus social dysphoria, right? And kind of breaking those up and knowing that both can occur. So for me, I don't have so much body dysphoria, but I have a hard time, every day, everywhere I go, I'm perceived as female all the time. So that gets old and makes me feel dysphoric, right? But that's not...
Tell them how you identify as.
Oh, well, I identify as non-binary / genderqueer, and I use they, them, their pronouns. So, getting my basic needs met in terms of pronoun usage and that stuff is really challenging, especially in just, very quick encounters with folks. So for me, that creates dysphoria for me in a way that isn't necessarily as related to the body as it might be for some other trans folks. So the three core ideas behind trans affirmative therapy, and if you all want this book, we can tell you where it is. It's fantastic. Lev is coming out with an updated edition soon, so you might want to wait for that. But it's a very specific text around how to work with trans folks in therapy. It's great.
Dr. Fromm has it in her office.
Oh, fantastic!
Get it.
Just go steal it from Dr. Fromm.
Under the bus, Dr. Fromm.
So the three core ideas are: everyone has a right to their own gender expression. Everyone has a right to make informed and educated decisions about their body and their gender expression, and everyone has the right to access medical, therapeutic, technological services and gain information and knowledge necessary to make informed and educated decisions about their bodies and lives. So really this is an empowerment model around helping people be informed consumers and have informed consent around what they want to do with their lives. Increasing your awareness. This is some of the stuff we've already hit, but that trans and gender nonconforming people might face different challenges. Think critically about how gender impacts your life. I think that's really important to do if you're trying to connect with trans folks, is thinking about what has gender told me about my life, how has gender impacted my life and where I am, what does that mean, where have I struggled against, if I identified as female and was a cis female, doesn't mean that I've always been like totally cool with being a girl. Like sometimes that sucks, and when does that suck, and can I talk about that and think about that reflectively? Same thing for being a guy, right? I mean, gender is a process I think that we all struggle with in different ways. Be conscious of pronouns and accept gender and assumptions about gender and be flexible. Here's what I would advise about pronouns. Practice pronouns, because if you screw it in front of a client, it's not probably going to be the end of the world, but it does get old if you're that client. So practice on your cat, practice on your partner, change their pronouns. Work on practicing that process of seeing someone and not have to assume that like, oh, that person looks like a woman, so they're a woman. Work on switching those pronouns around in your head, practice that. It can be really helpful over time. It gets a lot easier to assign people, pronouns based on what they want as opposed to what your brain automatically puts them in terms of a box. Does that make sense? I would practice because it's.
Just think about if you can't, if you mess up your client's pronoun, think about the rupture that it might occur in the therapeutic lines, and just think about the research around ruptures in the therapeutic lines and how that impacts therapeutic outcomes. So that's something to think about as well, because it can. I know you said that it may not be a big deal to your clients, but sometimes it is. Right.
What I would also work on too is if you screw up, acknowledging you screwed up and moving on. Because one thing, my pronouns are weird. People have a hard time using my pronouns. I get that. But what I don't want to engage in is a conversation around how weird it is to use my pronouns. Like, if you messed up, that's cool. Just move on and correct, and let's move on. But I've definitely had friends who've been like, oh, I screwed up again, and let me tell you how hard this is for me, and blah, 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 which I don't want to engage in when I just want you to use the terms I want you to use.
Can I just use this pronoun instead?
Yeah, we're not doing that either. Like, no, you just use what your client asks you to use and practice it, and try to take a little extra time to do that. And find resources and continue to have conversations about this with people. It helps to process this with other people. It helps to get supervision on these issues. If you're looking for resources, YouTube has everything you could ever want on trans people. There is no reason to not know what transition looks like or anything like that, because it's all on YouTube. You want to see what voice changes sound like on testosterone? There are 18 million guys who put up, this is me on T, week 1, 4, 10, 11, like, it's all there. You want to see what it's like for a trans woman right before she goes into surgery, they put it up there. The internet has been an incredible resource for trans folks, and there's a lot of information out there if you want to find it. I'm happy to help you access that, but also, if you just go looking, there are groups on Facebook that allow for non-trans folks to be in there as a supportive space. Go into spaces and listen and see what people are talking about. It's easy, it takes a little bit of extra time, but I think you'll get a lot of perspective on the trans community, that's also what I do. I just am in those communities so I see what's happening. I didn't get a secret trans newsletter or anything like that. I subscribed on Facebook.
I thought you did, because I got that.
Well, okay, well, you're a binary trans person. They don't give it to non-binary people, it's fine. And another fantastic resource that I would stress you looking at is this, which is the WPATH Standards of Care. So WPATH is the World Professional Association for Transgendered Health. These are their 7th version, their 7th Standards of Care, the version 7. Much better than the previous versions. This is what is the most commonly used standard of care for trans folks. It is not the only standard of care for trans folks. It's bigger communities like San Francisco and New York and Portland and Chicago, they do a lot more what we call informed consent models. With this kind of standard of care, what you do is you go in, you talk to a therapist, you get a letter, you go to your endocrinologist. There, that process looks like you go and talk to your endocrinologist and they say, cool, and they give you script. So regionalism matters so much in terms of trans access to care. So please think about that. But anyway, so these are guidelines for mental health and medical health professionals. Determine access to medical interventions such as hormone and surgery. This also frames it around gender dysphoria like it does in 5. Intended to be flexible in order to meet the diverse healthcare needs of trans folks, and individuals, health providers, and programs can modify them. So these are standards of care. This isn't a law. There are no laws around trans stuff. It's up to every provider to decide how they want to provide care. It's not standardized. I think people really do sometimes think that there's a law around what this looks like, and there's no.
Standardized.
It's not. It's highly variable. Can you hand me my soda, actually? Is that possible? And part of this is who are qualified mental health professionals. So these are folks with clinical training and practice in the following fields: psychology, psychiatry, social work, mental health counseling, marriage and family, nursing or family medicine with specific training in behavioral health and counseling. These are all the people within WPATH that we talk about as qualified mental health providers or professionals. So if you're going to be doing WPATH related work, so if you're going to be writing letters and thinking about that and working with clients, here are some things you should do. These are the requirements. For me, all of these things combined are what I think of as trans competency, so that might help kind of frame what I'm talking about. But like, first off, a therapist should be competent. What does that look like? I don't exactly know, but I think it involves all these things. So a master's level degree of training or better, knowledge about gender, non-conforming identities, expression, assessment, and treatment for gender dysphoria. So you're going to be assessing. How do you assess? Do you have any thoughts on that? Who have you talked to about this? These are all things that you should be doing if you're going to write letters for folks or think about writing letters for folks, or open your agency to writing letters for folks, because honestly we need people to be willing to take these leaps and kind of do this because we don't have access to care. And if you don't know these things, seeking supervision for someone who does. I can help you connect you with folks in the community who can do this, and we'll probably be happy to help folks start doing this process more. Recommendations that I think are pretty essential: knowledge about the trans community. You need to know about the trans community here in Louisville, not just broadly. Like, there are support groups in Louisville. What do they look like? They may say they're open to everyone, but like, who is it really appropriate for and who is it not? Like, who would actually get help here and who wouldn't? Be knowledgeable about that kind of stuff. Think about those groups. Ask around. Ask trans folks. Ask, just ask.
Yes.
Ask us. Be able to advocate for clients. Like Jaden had said, there are issues with IDs, there are issues with all these things, birth certificates and driver's licenses and schools, and you have to be able to step in and help clients get those needs met and advocate for them and help them advocate for themselves. So you need to know how those processes look and then how to help the clients actually get through those processes. Aware of public policy that affect trans clients, trans folks and their families. We just didn't pass a bill around not letting trans folks access the bathroom. You should know about that, because I could see a young trans person coming in freaking out about that. You should know that's a thing and not say, what are you talking about? If you're going to be doing this, you got to be more attentive to the trans kind of things that are happening, and it's happening rapidly, so I don't want to pretend like it's not. But just keep your eye out in the media. Flag it on your Google thing so that you bring up all trans articles so you know kind of what's happening. It's also really helpful if a therapist knows about sexuality, sexual health, etc. Trans folks, my dissertation is on trans folks and sexuality, so I like talking about this. But we don't know a lot about the sexual practices of trans folks broadly. We don't know how to keep them safe sexually because we don't know what they're doing. Like, these are all things that as a therapist you should work a little extra hard to make sure that you have some idea so you can help your clients not only stay safe but feel affirmed in their gender as they practice sex and sexuality, or know that they may not do that, and that's okay too. Yeah. This is a little bit reiterating what I was saying, but educate and advocate on clients within their community. So schools, workplaces, other organizations. Assist clients in making change to identity documents. Provide peer referral information. And this is a key I think anyone can do. Do you have a laser on this? Okay. This is really key, and I would encourage everyone to do it wherever you work all the time. It's the easiest thing you can do to A, figure out if you have trans folks, and B, make them feel comfortable. Take your form. Where it says gender, take away the boxes and put a blank. That's it. Do that. That is for me, a big step forward in feeling comfortable going somewhere. Pronouns are great. Pronouns are great, but even just having a blank for the gender A simple change, the private practice I'm working at, we talked about that the first time I worked there and changed that on the form so that trans folks can just write in what they want. Most people will write in male or female and that'll be fine, but it gives a little bit of space for trans folks. Having pronouns is fantastic. If you're working in a place that has like a receptionist, working on having preferred name and pronouns up there so receptionists aren't outing people in the waiting room. That happens all the time, especially in medical settings, but also in mental health settings.
But that becomes dangerous if it's not.
What?
In settings where the forms are not inclusive, at least my experience has been when I went to see my doctor, there was not a form that was inclusive for it. And so this is before I legally changed my name, and there was not a space for my preferred name. So when I'm very, very masculine presented at this point, and this person comes out and calls out my birth name, and you can imagine the looks that I got from everyone else in the waiting room looking at me and why I'm standing up for this very feminine name, right?
It sucks.
It sucks, so that creates a lot of dysphoria for me internally, but it also adds me to everyone in the waiting room and creates a very unsafe environment for me because as you can see, there's a lot of murders that happens with trans folks and trans people of color. So that's something I'm constantly thinking about. Am I safe in this environment? Oh, no, because I just got outed. And this does not happen, this not only happens in medical settings, but it can also happen in mental health practices. I worked at a community mental health where that is the norm, to go out into the waiting room, call out a name, and they'll come back. And imagine how dysphoric and unsafe that can be with a trans client for if they can't change their legal documents for whatever reason. And as you can see earlier with the slides, that a lot of folks can't. They don't have the resources or the money or the time or whatever reason that might be. They just can't. So keep that in mind with the barriers when it comes to trans folks.
Yeah, we might, and we have a little bit of time, but do you want to talk a little bit about how that process works of legally changing your gender and why it's so cumbersome? Because we talked about all the barriers, but I don't know if people understand what you have to do to change your gender legally.
Gender or name?
Gender. I mean, name is a much easier transition than changing your
Depends
gender.
on the state. So everything differs by state. There's no standardized way for all the states. So in the state of Kentucky, I can say with confidence in order to change your name, we're gonna switch over because we're gonna switch over anyways.
Okay.
In order to change your name, you have, at least in Jefferson County is a lot easier than other counties around the state. So Jefferson County and Lafayette County, which is Lexington, I think, either Franklin or Lafayette. Is it Franklin or Lafayette? Lafayette County. Lexington and Louisville. Those counties are super easy. All you have to do is you go to the probate court, you fill out a name change petition. It gets shipped to the judge signs it off. You get your court-ordered name change. You go to a Social Security office. You go to a DMV. You get your driver license, and then you can use that to change other documents, whatever that might be. With gender, it changes per state, right? So what is required in Kentucky is going to be very different from Indiana, which is only 2 miles that way. In the state of Kentucky, you have to have at least some kind of surgery. Irreversible surgery, whether that be top surgery, bottom surgery, whatever. It has to be some kind of surgery. And then you would have to go, you have to get a notarized physician letter from your surgeon stating that this is irreversible and that they are licensed and that you have undergone this surgery. And then you present that to the birth certificate. You have to present that to everywhere you go in order to change your gender markers. You go to Social Security, you go to the DMV. You don't have to change your Social Security and the birth certificate at the same time. You don't have to change your birth certificate if you don't want to. In some states, you're not allowed to change your birth certificate. In the state of Kentucky, they will give you a brand spanking new birth certificate. It's not an amendment, so there's no paper trail that goes back to your sex and sign of birth. But in other states, that's different. So I think it's Tennessee where you're not allowed. You can't ever change it in Tennessee. In West Virginia, there's absolutely no laws that address this. So it's kind of like the Hunger Games. It's kind of chaos. Like, oh, what's going to happen? I have a friend who's from West Virginia. He went to try to change it, and they're like, I don't know what to do because there's no law about it. Can we? Can we not? I don't know. It's chaotic. So depending on where you practice, keep that in mind of the laws that pertains to your clients. to trans folks.
And just how challenging it is and how much needs to be done just to get your documentation in line. I have friends who are trans guys who are getting flagged because they haven't registered for selective service, even though trans folks can't be in the military. That's a hassle. Folks who are having issues at banks because of name change, people who have background check run, that's an issue. Like
Passports.
passports are actually easier, almost easier than other things to change.
Right.
It's surprising for no reason. We have no idea why.
Yeah, but insurance, and then insurance, your medical care after you change the gender. If I change my gender on my insurance form right now, will I be able to have access to pap smears?
We don't know. Probably not.
Probably not. Depends on the physician, right? So it just really depends. So we're gonna go to just in general. So what Kenton just covered is more of like a therapist specific, right? What we can do as therapists to provide a more affirming environment for our trans client. But we also want to touch upon that, it's important to be trans affirming just in general. What can we do to be trans allies to our trans clients, to our trans coworkers, our trans peers, our trans colleagues, our trans family members, anyone, just random trans person on the street, like anyone. What can we do to make a safe environment for everyone around us? So with Trans Allyship 101, we have to understand that gender does not determine sex and sex does not determine genders. It goes back to the very beginning of this lecture. That not all trans people are interested in medical transitioning, so really acknowledge that when you talk to a trans person that we have this assumption that we know what their trajectory is going to look like. And it's all linear and it's all very spaced out in a very, specific linear, what? No, go.
I want to jump in, and I was trying to tap you to
Oh, go.
I was just going to say that one of the questions people get asked that is upsetting for trans people to be asked is like, have you had your surgeries yet? What surgeries have you had? Blah, blah, blah. That is none of your business. None. And I don't think that's you all specifically, but if you see other people doing that, it would be fantastic if cis people corrected people doing that, because that's way invasive. I'm going to set you up with someone because I know, because I had my friend who's a trans woman had someone at a medical office try to set her up with her gay boss, because trans women and gay men are the same thing, and that's the solution. I mean, so like that kind of stuff happens a lot, and just really trying to help rein other people in and give trans folks a safe place. It's surprisingly unsafe.
Yeah.
It,
So kind of reiterate that trans identity is part of the human diversity. It's not something to be fixed. It is no less normal than any other identity out there, right? We're just as much of a human being as anyone out there. The trans community is amazingly diverse. It includes people of all races, sexualities, classes, ages, sizes, religions, ability, status, etc. The trans community can never be represented by just one individual or generalization. So we are trans folks. We are standing up here talking about the trans community, but we don't represent the trans community. We can represent us. We can represent our experiences. We, to a certain extent, can kind of represent our research participants that are participating in our qualitative study, who we have had extensive interactions with and have heard their stories. But overall, we really can't represent the trans community. And this is important for us for everyone to really talk to trans folks and talk to the trans community and be up to date with the trans community, because it's ever changing. And you do not have to be a trans person or an expert on trans issues to support trans people, right? You just have to be a decent human being. That's all you need to be. So the do's to be a trans ally, or steps towards trans allyships, to use trans affirming language, right? To really support and use the pronouns that trans person wants to use or identifies with. Politely, when you don't know, politely ask what pronouns and names a person prefers you use when referring to them. And we also have to think about safety issues. Are they out to other people? Think about the settings that they're in. I have a trans woman friend who is early in her transition. So in our space, our safe space, we refer to her with her preferred name and her preferred pronouns, but she's not out to anyone else. So outside in public, we don't use that, because that might out her as a trans woman. That might put her at risk, in danger. Respect the rights of trans people to define themselves and self-determination. Take trans people and their concerns seriously, even if you do not understand the concern or why it is important to them. This goes along the lines with really doing your own research and really understanding what is important in the trans community right now and what different issues are out there that might arise. Be mindful of where trans people cannot go and make sure you provide resources, similar with the bathrooms. Or even though there's not, for adults, trans adults, there's no legislators that tells us that we can and cannot use a bathroom that, for our gender. But it can also be unsafe, especially folks who are still early in their transition or do not pass as the gender that they identify with. It can become a very big safety concern. So early in my own transition, I didn't really pass and I didn't really feel safe, but there were some of my friends like, you know, let's go to the bathroom real quick. I'm like, I can't because I don't know what to do. Is it safe for me to do that? Am I going to get beat up? I've had a friend get beat up in the men's restroom because someone clocked him and found out and tried to beat him up. That's unsafe. Again, educate yourself on issues that are important to trans individuals in the community. Stay up to date with the discourses of the trans community. The discourses in the trans community is changing rapidly. You know, it changes all the time. I did a research on trans folks 1 year and I had to completely change the language of it the next year because it changes so quickly. Ask questions respectfully. You know, don't out of nowhere within the first 10 seconds of meeting one, like, are you trans? You know, just be really mindful of how to ask someone a question. Was there something you want to ask? No? Okay. Be open to discussions about gender and how it affects situations in your life and the lives of those around you. So regardless of if you identify as trans or if you identify as cis, that gender affects all of us. You know, gender is a very social thing. It affects everywhere around you. I challenge you to go out today after this and try to be cognizant of the gendered things around us. We have gendered bathrooms, we have gendered clothes, you know, gender
Mom, labels. Dad, brother, sister, niece, nephew, son, daughter.
Right. Mrs., Mr., everything. A lot of things around us are gender. So I challenge you to really be cognizant and think about how that might affect trans folks, and specifically trans folks who identify off of that binary, right? Challenge gender assumptions and transphobia whenever possible. You know, we recognize that sometimes it's not the safest for folks to address it. You know, I've known people who have been beaten up because they stood up for someone. But if you can, if you feel safe enough, please do it, because sometimes trans folks don't have a voice to be able to do that. And as cis folks and as allies, you have more power than we do. You have more voice, and folks are going to listen to you more just by default. So use that power that you have to really advocate for the community if you can. And be supportive and be a good listener. And I feel like as therapists, this is something that we should be able to do, right? You'd be surprised when you encounter someone who doesn't. And educate other potential allies about trans issues and allyship. You know, be a visible ally. Visibility is incredibly important, not just for trans folks, but for folks in general. Visibility, there's a lot of power when it comes to visibility. You don't have to know a person to see a person and know that people exist. If I knew a trans person, a trans ally exists, that gives me comfort. If I know there's a trans ally in this building, that gives me a sense of safety. There's something that someone that I can go to if I need help. They are a safe base for us, at least for me. Don't assume that all trans people want hormones and surgery and that is the only way to transition, or that transition is a linear process, you know, something that what we just said. Don't out a trans person without their express permission. That happens very often, and that's very similar to the waiting room incident. It's really easy to out a trans person, and when outside of here, I hope that folks will respect my identity and not out me to folks around them. Unless I give you permission. You know, there's certain cases that I feel comfortable with other people knowing, but some cases that I don't. So I hope that everyone will respect our identity, both to keep it within us. We hope that you take away our stories and our experiences and what you learn from that and share it with other people, but when it comes to us ourselves, I hope that you can respect our anonymity. Don't assume an individual's sex or gender identity based on their appearance, so that difference between gender expression and their gender identity. Don't assume that because you cannot visibly identify anyone in the room as trans, there are no trans people present. I'm pretty sure that if you had seen me before this presentation, that you would not have thought that I was a trans person. Twists. Don't place labels on people. Don't refer to a trans person as it, he, she, he, or any pejorative terms unless the individual has specifically asked you to prefer them in such a manner. There are individuals in the community that they feel perfectly fine identifying with a very pejorative term, similar in the queer community where there are some folks who identify with the F word, right? Everyone know what the F word is? It's a 3-letter word. It's so it's very similar. You know, there's in the trans community, there's the T word. Everyone know the T word? It's a 6-letter word. Starts with a T, ends with a Y. It's very pejorative. Talk to me afterwards if you don't know.
Here's what I was going to say too. Like, this actually happens a lot more than you think it does. If you start listening to music and terminologies people use and watching shows, you'll see it come up more and more, and it's really upsetting. I have a friend of ours was sitting at Garage Bar and listened to some guy say negative
Medical provider.
medical providers say pejorative things about trans people, thinking no one was around to listen. That happened like last week. So it happens a lot, and what I would really hope that folks would do is if you see folks doing that, ask them to stop, use some other terminology. We can't do that.
No.
It's too much. There's no reason for that.
No. Don't put chosen name, chosen pronouns, or self-identification of a trans person in quotation marks. So, what? Did you? Shame on you. Nah. Don't say Jaden did this, or you know, his name is Jaden. What? No. Don't deny your privilege. You know, as folks who are not trans, there's a lot of privilege that comes with that, and I wonder how many folks, before you came to today's presentation, took for granted a lot of the very simple things that trans folks have to struggle with, like bathroom use, or insurance, or name changes, or legal documents, or basic healthcare needs. That's something that folks have, and you have the privilege. Use that privilege to do good, to advocate for others. Don't assume that everyone has equal rights. You know, don't ignore the facts that acts of discrimination, or to be complacent when you see things happen. Don't be defensive when trans people call you out on it. When we call you out on something that you have said, we're actually showing you that we trust you enough to be able to address it with you in person. That shows that we trust you. Because in other cases, if we don't trust a person, we try to call someone out, that could put us at a risk. That could put me in danger, our very lives in danger. So when we ask you and tell you like something that you said is, you know, problematic and let's learn from this and have a discussion about it, we're telling you that we trust you enough to have this conversation. And don't perpetuate stereotypes. I mean, that's pretty much self-explanatory. So remember, it's okay to make mistakes. Kenton just made a mistake. They're trans. I make mistakes all the time. I'm trans. I mean, I make mistakes about my own identity all the time. Just last summer, I did a panel speak out, and I introduced myself. I introduced myself with my birth name. What? I've been transitioned for years, and I did that, and what just happened? Right? I make mistakes about myself sometimes. I make mistakes about other people's pronouns. I know I made a mistake with your pronouns a lot when you first started transition. It's okay to make mistakes as long as you make them learning opportunities, right? Can you learn from them? Can you improve? Can you make sure that you don't perpetuate this cycle of mistakes and continue to mess up in the future?
I would also say, like, I think you can be attentive to times when you're primed to make more mistakes. So like I had a friend, they were married and one of the partners was a trans woman. When I talked about them being married, I was much more likely to misgender her, right? Because marriage invokes man and woman, and that's when I would screw up, right? So like there are spaces like that. If you can be attentive to them, if you can start changing your language around change marriage to partnership, then you're less likely to even screw up there, right? So I think there are places that you can also, if you're being attentive, know where you make mistakes and try to account for it and just work around it.
Right.
So that's.
Yeah, and then like if you want more do's and don'ts, there's a huge list at this website. It's like 4 or 5 pages long. It's gigantic, and what I put up there is just a snippet from that list. But it's a really good list. I encourage everyone to take a look at it and really think about what's on the list. But overall, did everyone get the link that want to? Okay. If you have any, we're gonna have like a quick 15-minute, 20-minute Q&A. But if your questions aren't addressed today, these are our contact information. This is our Facebook page.
You should like it for no reason.
You should like it for no reason at all. But you can contact us if you have any questions or consultations or clarification. Please let me know or let us know.
What questions you all have, or anything that we can clarify for you all further? I know you've been sitting here for like an hour and 45 minutes, so I can see why you'll answer. But
Right.
if people want, or if it would be better, we could dismiss, and if people want to come up individually and ask specific questions, and I feel comfortable with also do that.
I like the general lecture field. Because people can learn.
Yeah, people are both. Yes, it's true. But
Both.
people are time, and then we're-
Right.
So,
If there's no general questions. Dr. Prashant.
Might you share some of the community resources that you all mentioned of being in the know about that are here locally?
Yeah, I think, is there something on our Facebook page that has like some resources on there? I feel like we do.
I was going to talk specifically about community group kind of stuff. So I would say for folks under 21,
Yeah, under 21, LYG.
LYG would be the place to go, the Louisville Youth Group. They have specific support for trans youth. In addition, there are some support groups in terms of, we don't have therapeutic groups or therapeutic spaces specifically for trans folks, which is a challenge.
They're starting to pop up in private practices. You just kind of have to go out and look for it.
Yeah.
I know Dr. Bridget Kleinman has a group. I know Dr. Weinbarger has a group for parents of trans folks. At least I think last time I checked in with her, she's in the process of developing that. I know Dr. Johanna Moores has a trans group. And then at my new practice site next year, I plan on starting a trans group as well.
I would say that generally the best access to care for trans folks is in a college setting. It's much, much harder to get kids access to care or adults who are not in college access to care.
Right.
I would also, there's a trans feminine group called Sienna, there's a trans masculine group called Louisville Trans Men. Those are both groups that are out there for adults, but they're support groups and not intrinsically meant to be therapeutic.
Yeah. With Sienna, it's generally catered more towards like older trans women.
It is. I would be less inclined to send younger trans women there.
Yeah.
Just because it's not as much of a space for them. So, any other specific questions about resources? Yeah.
For folks who are medically transitioning, do the medical providers often look to the psychological community to provide some affirmation, reports,
Yeah.
evaluations?
Yeah, under the WPATH standards of care.
Oh, shut. Go. Do it.
Yeah. So this is how this operates under WPATH standards of care. We need one referral for access to hormone therapy or chest or breast surgery, right? And that needs to be from a psychologist. So what you do generally, and I've done a couple of these evaluations. Other folks I know have done more, but the idea is that you usually meet with a client for 2 hours or so and do a psychological evaluation that may or may not include psychological testing. Usually it doesn't, but it does give you an idea of their history, what's going on, current presenting mental health problems, those kinds of things. You take that, you write that letter up, you send it to the endocrinologist. One of the things that's really important about trans care is making sure that you know who the endocrinologists are and you know who the providers are, so that you can write letters to people the way they want them to be written, so that they can get your clients access to care. But under WPATH, you're required to at least have one referral for hormones or chest surgery, and then if you want to get a
Bottom
hysterectomy, metoidoplasty, phalloplasty,
Bottom surgery.
Bottom surgeries, 2 referrals from 2 different psychologists. So where this gets expensive for trans folks, and I think this is important to know, testosterone is not particularly expensive. Estrogen and spirolactone, which is a commonly used T blocker, are some of the most prescribed medications out there. They're super cheap. What gets expensive is the blood work from the endocrinologist, meeting with the endocrinologist, seeing the psychologist. Hopefully they'll give you one evaluation session instead of charging you for 6 months of therapy. That's not the standard of care, but people are still doing that. So I need to see you for so long before. We also see that For some providers who, from endocrinology providers, binary trans people are fine, but when non-binary trans people show up, well, I need you to be in therapy longer, or I need this, or I need that, they're not as willing to write scripts. Even though it's in WPATH, they're hesitant with non-binary folks, especially non-binary feminine folks. So those are some of the barriers we're seeing.
I think there's also still the misperception in the psychological community that you need 2 years of therapy before writing a letter.
Yeah, no,
Which is absolutely
no.
several letters for both for top surgery and for hormones, and they've been really simple letters, not full assessment.
Yeah. Other folks?
Yeah, I don't know how you define an assessment, but usually it's like a history and, you know, like an intake, but with a gender focus. The person I worked with under Dr. Stephanie Budge, she would do some screeners to have ideas about, you know, we're seeing some experiences of depression and anxiety. She liked putting that in there so you could justify why you're going on hormones, right? If the treatment for gender dysphoria is hormones, saying there's a, you know, this person experiencing depression and anxiety adds weight to saying, and they need hormones to treat that. What about for anyone else?
Other folks?
Going once? Yes.
I have a question. So I've noticed, I'm very early in my training, but when I have clients and I ask them, because I don't want to assume like a race, you know, I say, how do you identify racially? And I look really confused. You know, and it's often very like awkward, falling flat for women.
Mm-hmm.
So with gender, how do you phrase the question? How do you know, what is your gender identity? And then what do you do when you get that confused face?
Mm.
This is why I like putting the blank on the form as a way to not have to do that specific question. I mean, sometimes you may need to still do that, but I think providing a blank space can be really advantageous in that most people are going to put a you know, a cis identity and some people won't. What are your experiences in terms of asking that question and throwing it out there? I don't have as many, I have more assessment experience and less of that.
I find that with folks who are either trans or are exploring their gender, they actually feel really relieved that you asked that question, because that gives them a space to be able to answer it fully to how they identify with. But folks who don't even think about it, you have that blank space, and that's fine. I would suggest.
But I think you can also frame it around like, well, tell me a little bit about your experiences with gender. Like, I mean, I come from more of a feminist therapist perspective, so that would make a lot of sense for me. But like, you know, what was it like growing up as a girl or a boy? Like, I think you could turn that to make it applicable to anyone. I feel very strongly that gender is a game that everyone loses in some way. Cis or trans, right? We're never quite good enough to measure up to the gender expectations we have. And if that's kind of a space that you like to work or think about in terms of gender, I think you could ask those questions.
Yeah.
And it wouldn't be so like, ugh. That's my thought.
It's a good recovery.
Steph, doing the John Black.
I'm just curious, especially since I'm going to be working more in like the Portland and China neighborhoods more this summer. It struck me that I'm sure there are trans folks there, obviously, but spirituality and faith-based groups are also really important for a lot of people in that community in particular. Are there any like trans-affirming faith groups in Louisville, or how would I go about finding those so that I can share them?
It's more from word of mouth. So a lot of the things that are affirming in a trans community is from word of mouth, because someone has lived through it and can speak for it. With faith-based groups, I know of at least 1 or 2 churches that are very open and welcoming of trans folks. And that's something,
Pretty white churches.
those are also very white churches.
Okay, intersectionality.
Right.
No, I mean, the ones I'm thinking of are like Metropolitan Community Church, those
Yeah.
kinds of places have
Even-
historically been very, the Presbyterians have been nice to trans folks, and in fact, the Presbyterian Seminary usually hosts the Trans Day of Remembrance or the Trans Week of Remembrance events. So those kinds of groups I can talk to more broadly, and maybe we can figure out ways to get you, I get you, I can.
Those are
I
also
can,
pretty white.
that's true, but we can get you, I can find you someone.
Yeah.
If you have a client that needs those kinds of resources. But broadly, I don't have a good idea, like especially if you're in a new place doing different kinds of work, how you find those without knowing the community.
Yeah,
It's very,
hard.
so that wasn't a fantastic answer, but yay.
Anyone
Yeah.
else?
How bad, yeah.
You mentioned affirmative therapy for treating gender dysphoria. Are there any other evidence-based treatments that are used to work with gender dysphoria?
EBTs.
Maybe like depression?
Oh, like evidence-based treatment?
Yeah,
that kind of
EBTs.
thing?
Yeah.
No. No, I mean, I don't know. Do you have something more? I mean, my feeling is like I know that Stephanie Budge is beginning that work on. We don't even know if therapy is useful for trans folks. We've just required it because that's what we wanted to do because we didn't want to give them access to this care.
And that's what medical providers require.
Right, but why that process happened, I don't intrinsically know. Other than like the standards of care have been around since
1950s, 60s, yeah.
60s. Harry Benjamin wrote the transsexual phenomenon in 1966. That started being the first time we started seeing these ideas brought out more broadly. But the efficacy of therapy for trans folks, we don't really know.
Well, the research with trans folks are still so new that it's really hard to figure out, what's evidence-based anyways. Like with us, we're pioneers in research with trans folks. No,
But there are no psychotherapy studies with trans folks.
No.
Unless Stephanie starts doing them,
Right.
right? I mean, so that's where we are. So we've been requiring for 50 years that people go to therapy for no evidence-based reason.
Yeah.
Now that has been limited, at least in WPATH, to an evaluation that's 2 hours as opposed to 6 months or 2 years, or living as the gender you identify with, but without hormones, so that you'll be, I guess, more targeted to be hurt. These are concerns I have. Does that make sense? But I don't know.
Do you know of any other countries that you feel like handle the situation better, and if so, like in what ways?
Other country?
other countries that handle it better.
Canada pays for stuff. Canada pays.
Yep.
And, nationalized healthcare systems pay for transition. That would be a big start for us. Thailand is much more open and a lot more.
There's less stigma.
There's less stigma. They're better. Their doctors are. My understanding of Thailand doctors is that they are trained collectively, and in the U.S. it's a one-on-one model, right? So like you have multiple doctors training to do these kinds of surgeries, and here you have essentially like a one-on-one apprenticeship model. So you have a couple of providers in the country that people would call good, but not the same kind of standard of care related to trans health that you would there. But those are my thoughts. Anyone else? Nothing, Koji.
All right. I think we can be done if there's no other questions.
Thank you all so much.
Thank you so much for coming.